Very good evening and thanks to everyone for joining us today. I, Ankit Dogra, along with my teammates Dr. Deepika Chhabra and Mr. Amit Saxena from Medical Services Jagsonpal Pharmaceuticals Limited, welcome you all to the next episode of the series Pearls of Wisdom, Key Opinion Leaders, organized by the Society of Meaningful Life Management. The academic partner for today's program is Jagsonpal Pharmaceuticals Limited, makers of Divatrone, 10 mg tablets of micronized dydrogesterone, indigenous and affordable for a safer and smoother journey to the motherhood, along with Injection Maintain, 500 and 250 mg depot 17 alpha hydroxyprogesterone caproate to maintain normal pregnancy till the term, and LycoRed Preg sachets of L-arginine, Lycopene and DHA for high-risk pregnancies. We extend a warm and hearty welcome to all the esteemed speakers, experts, and the attendees. Dear attendees, we request you to post your thoughts or opinions by the text in the Q&A box. Please note this webinar is streaming live on the Facebook and the link has been shared in the chat box. To refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights, as its complete recording will be uploaded there. We welcome and request Dr. Maninder Ahuja, the progressive thought-provoking leader, creator of processes of going digital, online voting, e-newsletters, online journals, and the founder president of SMLM, past president Indian Menopause Society, and Faridabad OBSTETRICS Society to kindly initiate the proceedings. Over to you, ma'am.
Good evening, everybody. Thank you, Jagsonpal, for being the technical partner of my webinar series. And in this webinar, we are going to talk on a very important topic, which is the vasculopathies in the obstetrics, and keeping the interest of the our delegates and respecting their time and the choice of the topics. We are keeping just one topic so that we can discuss in details and the carry home messages can be very clear. And in today's webinar, we have three Digvijay, Maharathis, our teacher of teachers, Dr. Pankaj Desai, Dr. Manju Puri, and Dr. Manju Khemani. The aim of the Society of Meaningful Life Management has been to do the things which are practical, feasible, and meaningful, so that they add a meaning to the doctors, patients, and the patient and doctor relationship and the media relationship and all that. So we have been working on those directions, and our aim is to get the meaningful something. Research also started in our country where we are lacking a lot. So we have with us our main speaker, Dr. Pankaj Desai, who I think just does not need any introduction because he was not only the past president of FOGSI, but consultant OBGYN specialist, Janani Maternity Hospital, Baroda, former dean, associate professor and unit head of Medical College, Baroda, gold medalist awarded in OBGYN. There are 60 orations, guest lectures, 752, publication, 107. He's very methodical in his work. That's why he has given even the exact numbers, and research paper, awards, books authored, contributions to chapter, different textbooks, peer member, editorial board to OBGYN journals 5, blogs published 25, read by lakhs of people. He has written number 92,000, but it might be more than that. But what people, perhaps none of you knows that he was the first one who started a website which is still working even today. And he's one of my mentors. He was the first one. When I attended his first lectures, I was such awed by his lecture. I just stood up there in the middle and just started clapping at the end of it. And that was from my heart only. And then next time when I met him in the Gurgaon he was already a president of FOGSI at that time. Sir, I want to start writing, just guide me. And he gave me those pearls of wisdom. So those pearls of wisdom, I think he'll be sharing even today. He told me one thing, write, then cut, be your own editor. That is perhaps the most difficult thing to do. So, sir, I can never forget those contributions of yours to my life. So I always remember you, always miss you. And you know that I always come to you with for the right advice also. So some notable honors and awards are Visiting Professor Fellow, Liverpool Hospital, Sydney, Australia, Young Gynecologist Award by AOFOG, Bangkok, 1991, as soon as that, early that time. Tamaskar Award for Best Work in Infertility during 1993, International Fellowship Award, Indian College of OBGYN, 2003, Best Publication Prize, Best Published Paper, by the Journal of OBGYN India, and past president of FOGSI, which I have already highlighted. Sir, it's more than our honor to welcome you, but I would like to at the same time welcome our other teachers of teachers, Dr. Manju Puri, who is the director, professor and former HOD, Department of OBGYN, Lady Hardinge Medical College, New Delhi. If you have to search for a teacher in Delhi, I think you name Dr. Manju Puri. And if you need anybody help, she is there. And she is such a great academician that I just, if I talk a lot about her, that will be just like showing a diya to a Suraj. That is just like that only. So she is the presently chairperson of Safe Motherhood Committee of Association of Obstetrician and Gynecologists of Delhi, National Coordinator for Practical Obstetrics Committee, FOGSI, President-elect National Association of Reproductive and Child Health of India, Delhi, and Subject Expert Committee, Central Drug Standard Control Organization, National Mentor Lakshya Implementation in Medical Colleges, External Quality Assessor for Public Health Facilities. How she finds all time for all these activities is really beyond our imagination. And she has edited so many books: Anemia in Pregnancy, Management of High-Risk Pregnancy, A Practical Approach, Clinical Methods in Obstetrics and Gynecology, and field of interest is, of course, high-risk obstetrics, quality improvement, and reproductive endocrinology. So, Dr. Manju Puri, welcome here as an expert commentator, or as I call, Manthan of Dr. Pankaj Desai's talk later on. Dr. Manju Khemani's please CV, so that it's an honor, Dr. Manju, to welcome you here on this platform of Society of Meaningful Life Management. She is the Senior Director of Department of Obstetrics and Gynae, Max Smart Super Specialty Hospital, New Delhi, and ex-Professor Lady Hardinge Medical College, New Delhi. And we have been seeing her so frequently and talking on so different subjects in the webinars. Past Chairperson of the Endometriosis Committee of AOGD, past Chairperson Safe Motherhood Committee of AOGD, Fellowship in the Advanced Gynecological Endoscopy done at Bombay Endoscopy Academy and Center for Minimal Invasive Surgery, Mumbai, and past President of DGHF, that is the Delhi Gynae Obstetric Federation, Review Editor of Jogi, and recipient of Abdul Kalam Award. Dr. Manju Khemani, it's an honor to have you here, and I am sure that we will be sharing many pearls of wisdom among our delegates. Dr. Deepika, can we show their mementos, please? Honor them with the mementos which you had. Have you the pictures or the mementos? Yes. Dr. Pankaj Desai, I just don't have words to thank you, because might not be late later on. So I would like to give you this honor at the start even. Dr. Manju Puri, yes, it's a Society of Meaningful Life Management welcomes you here, Dr. Manju Puri, and honors you for being great teacher of teachers. Dr. Manju Khemani, please, we are really honored to welcome you here as a expert opinion maker. I think with these words, we should start our proceedings, because we always want to finish in time also, so that we respect the people's timing and their commitment to others. Thank you very much. Let's start, please, with Dr. Pankaj Desai's talk, and then we'll be having the comments later on by Dr. Manju Puri, Dr. Manju Khemani. And if there are any questions, please post them in your Q&A box so that we can answer them later on.
We reverently pray for eternal harmony in the universe. May the weather be seasonable. May the harvest be fruitful. May countries exist in harmony. And may all people exist in happiness. For my friends who are here and who may like to know about this lecture later on, I have always felt that a lecture once over should not be thrown away. Many times you require references. Many times you require to go through it again, and today for sure, because I'm going to share so much of new information to you, for some of you, not of course to brilliant academicians like Dr. but like Manjus, both Manjus. I know them. They are brilliant people. They must be knowing all this, what I'm going to share. But there might be some who might be new, and therefore my recording of this lecture is already available in a different format. If I get exact verbatim of this, then I will upload this as well. The text of this lecture is already available on this website of mine in my recent lecture section. And all the participants can mail their queries to me on this email ID. I will surely reply. Okay, we come to the main body of the lecture. And normally the lecture is from old to new, or what is new? No, I am going to take you from what is current to what is new, because current itself is still unsettled. Current has still not sunk in our minds, in our brains, and there already new things have started coming. So Maninder's this needs to be congratulated. Subject choice, because usually it is old to new. Here it is already current, and I'll be showing you what is current and then go to what is new. So the topic obstetric vasculopathies, what is new? I know you all know now that these are not vasculitis, but vasculopathies, and that means the fetoplacental level, at the fetoplacental base, the problems are taking place. Those conditions in early pregnancy or early vasculopathies are the recurrent late missed abortions, and the other ones are preeclampsia remote from term, then stillbirths, preterm labor, accidental hemorrhage. All these are, and preeclampsia remote from term means 32 or 34. Let that controversy remain amongst the Western literature and ours. But we are following 32. The Westerns wanted a 34. Doesn't matter much. The pathology is more striking, and that we'll be seeing now. What is the current thinking? As regards the etiopathology is concerned, the current focus is on immunology. And I have covered this extensively in these two books of mine. The book here, this is not come much in India because it was published by Cambridge and in Cambridge, and it is being sold in England and Europe. A little costly for India. It costs around 6,720 rupees because it gets converted, for euros get converted. It is selling there very fast. Unluckily, I have been requesting them to bring it down to Indian level so that we can get in around 1,000. That is what our practitioners find it acceptable. But still, it has not come in a big way. But it is there, and these books, you can have it from my website. You can buy it from my website. This is the website. Now, why do obstetric vasculopathies occur? I told you it's immunological basis. Because of immunological problems, and we are not going into details, there is incompetent placentation. Please mark my words. The placenta is at fault. because there is a failure of second wave of trophoblastic invasion. Now, when there is a failure of invasion, this area remains uncovered or unmolded, because the trophoblast go and mold the arteries, mold the arcuate arteries, mold the spiral arterioles, and they convert themselves into feto-maternal vessels. But in patients in whom these fails, these remain uninvaded and these areas remain uncovered. Now that uncovered area becomes the seat of release of free oxygen radicals. All mischiefs take place there, and which subsequently leads to denaturation of lipids, which swarm the maternal vasculature, producing a vasospasm, resulting in clinical preeclampsia. The mother senses that there is a spasm. She tries to push in more blood. She cannot push in because there is a spasm. She raises her blood pressure. And you call it as preeclampsia and its subsequent complications. I'll be taking you now into the vessel as to what is the current thinking. And you can see here, this is the unmolded vessel. And between the two cells in the subendothelial matrix, this is the area of mischief. What happens here is that the HDL, by its electronic configuration and atomic configuration, remains away from this lining. But LDL and VLDL tend to sink in. This is the unmolded vessel where this mischief is going to take place. Now, once they start sinking in, as you can see here, they sink in, and what happens is that the reactive oxygen species, they bombard. And they bombard here, and they denature the LDL and VLDL. You can see HDL is above. And this is all taking place in a state of vasospasm initial. But that is not causing the mischief. I'll be coming to that a little later, within minutes. So here, what happens is that the LDL and VLDL get peroxidized. Still, they are sitting in the vessels which have undergone spasm, the narrowed vessels. But when this spasm gets relieved by a natural protective phenomenon, which always occurs, then these lipid peroxidized, they are flushed into the circulation. And they go all over the maternal body. Reactive oxygen species are not in a position to swarm the entire vessels. They are like the ACAs, the trans-border ACAs, who send the trained terrorists to our country, and they create the havoc. So these peroxidized LDLs and VLDLs are those terrorists whose ACAs are ROS who are playing in that space. And wherever this LDL and VLDL goes, they produce a vasospasm. So this is the mischief of vasospasm and reperfusion. Vasospasm, reperfusion. So the basic pathology just taught to us in right from MBBS days is vasospasm, agreed. But now what is accepted is that it is not the vasospasm, but the reperfusion damage that invites vasculopathy. Understand this. Now, what is this? What I mean to say, I'll make it more explicit, because that is what Maninder told me, that make it as explicit as possible so that the practitioners can understand, and then they can imbibe your messages as regards clinical practice. What you are seeing here, you are not seeing some ice. It is actually a frozen wave, in front of which some lady is standing. This is a frozen wave. This is a state of vasospasm. It has undergone a spasm. And when warmth comes in, the spasm gets relieved and the lady is washed off. This is reperfusion damage. We have worked on animal experiments and so many things here and all internationally published data. But reperfusion damage is the gush of blood once the spasm is relieved. It flushes in the denatured lipid moieties which incite a vasospasm in the vessels, and you call it as preeclampsia or stillbirth or missed abortion or so many other vasculopathies. Now I come to the clinical area. Now on the basis of this, we have got prediction tests. All of you know that basically there are two sets of tests. One is color Doppler and chemical biomarkers. we are so much sold out to chemical biomarkers that now I have seen practitioners or even associations who are considering it as a matter of pride that they are getting. It's okay, I have nothing to say, but there's a matter of pride that they are providing now assessment of biomarkers at a concessional cost for prediction. However, color Doppler itself can tell you in a much advanced way. And that is what is the new thing, not new as per this lecture, but that is what may be new thing for some of you. Clinical biomarkers are time consuming for India. They need an extra visit to the laboratory. Most of the practitioners don't have the setup in their own laboratory. Maybe where Dr. Manju, both the Manju squares are practicing, it is there in their lab. But not everywhere, not in my hospital, though it's a big hospital. We don't have a lab here. Somebody comes and collects the blood. Patient pays extra through our own resources. So do we have something which is like this fountain? Simple, cheap, easily available and reliable. Yes, with data I will tell you. PI more than 1.7 at 11 to 14 weeks. Please remember, very simple message. PI more than 1.7 is used at first trimester to predict preeclampsia. Many papers have been published. So we also studied it. 264 prospective leakage. All this published data, I will show you where it is published also. The chi-square value was significant with a very high negative predictive value and a very high accuracy. So PI more than 1.7 at the end of first trimester around 12 to 14 weeks. Remember this. Now, while we were doing this, we closely observed one phenomena which was taking place in the color Doppler. You also must be seeing it, but you are ignoring it. Or probably you have not been sensitized to it. It is a failure of me as a teacher. If I would have sensitized you, you would also be seeing it. And if you see, just observe, and we observed this, we saw this diastolic notch. Now you all see this diastolic notch at least in the reports which you get, and you just ignore it. I and my team started observing this diastolic notch very closely. This is a common finding, consistent finding in preeclampsia at 11 to 14 weeks, when the preeclampsia has not yet developed, or even she is just 11 to 14 weeks. But you see this diastolic notch. From the age, you can make out the different patients. See this diastolic notch and see this diastolic notch. The depth is different. So that is where somebody started singing this song, which became very famous. Sun, 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 barsat ki dhun sun. Sun, 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 ye diastolic notch kya keh raha hai? Sun. Kuch hai kya udhar message? So we started measuring it. We started measuring the depth of the diastolic notch, and it is called NDI, the notch depth index. In the meantime, our Japanese friends also started studying with us, and they also started corroborating our data. And what we found was that the same picture I am bringing in, here the NDI was 0.371, and here the NDI was 0.121. Okay, this was the first observation. Now, we started correlating it with following them up prospectively. बाद में क्या होता है? We started analyzing it as this gentleman is analyzing. And what we found, again, more than nearly 300 subjects, prospectively followed up till delivery. Significant number of them develop obstetric vasculopathies, including preeclampsia, with a probability was less than 0.01. The specificity is so high and a high accuracy of nearly 80%. Now, what they are doing in the Doppler and the biochemical markers, they are reinforcing the two. What we did was, let us reinforce also and see, so that we can match their data. Their data is excellent. We have to match it with quality data. What should we do? And they are reinforcing it through these PAPPA, PGF, and SFLT1. Because these countries do it, even if they have upper respiratory infection, we start sneezing. The whole world has already started doing it. But we found that in our country, this may not be so practical. Only on color Doppler you can help it. So we started combining the two data. And 264, there are different cases. The total might come to 600 plus and now much more. This is, I have brought that published data here. 264 prospectively subject followed up subject, analyzed through 3 statistical machines, tools, and the chi-square value, the probability value, and the specificity and predictive value, plus accuracy value, and everywhere it stood the test of time. Then I love my data to be challenged. I love my data to be scrutinized. मैं बोलता हूँ इसलिए नहीं. मैं कौन हूँ? मैं कौन हूँ? Who am I? Nothing. I am just one Aradhak of Ma Saraswati, and I am trying to unravel mysteries and share with you. So I sent it for intense security, scrutiny, sorry, and it came in this. One of them came in this. This is one of the papers in international. This international journal on pregnancy hypertension, and was nominated for the best paper prize for that year, just 1 or 2 years before. I'm not going in further details, but this is the message. This is the job given to me by the boss, Maninder, and that is, he said, please summarize the message of the wise in this. So the message is PI more than 1.7, and suppose you can do a combination ideal, PI more than 1.7 or NDI more than 0.5 are both high risk factors. Start preventive measures, start aspirin. This is the case where even in a primigravida who has no past obstetric performance, these are bugging us. And we find that primies are most susceptible to these conditions. What should we do about it? Nothing. We were up till now just sitting silently. No, start. In these cases, start aspirin. And we are having excellent results. Not bringing in here because of the paucity of time, as it is actually can turn out to be an oration. Then so in a comprehensive way, some other aspect. We went in second trimester also. And if you find that normally a diastolic notch should disappear by second trimester. However, if you find that there is a diastolic notch still present in the plate which is sent to you, you might not be doing the second trimester scan. Don't worry. And none of your, my city now, they have started writing the diastolic notch present or not present, because we people like me are now insisting the diastolic notch देखा क्या second trimester में? हाँ sir, एक vessel में है. That is a high risk subject. If you have started preventive measures, please continue. In others, we have started stopping also, but hardly 85 cases, so not able to give you more data on this. We stop preventive measures if there are low risk subjects, but we will not mire your data or understanding. अभी छोटे-छोटे steps लेते हैं. So for the academic minded, and we have 2 teachers here of the past, both of these, Dr. Manju Square, again I will tell them, brilliant people as I know for years together. NDI alone, 0.5, is also very competent in predicting PI of vasculopathies, including PIH remote from term. This is current thinking. Now I am jumping you to novel thinking. What is new which has come? अरे यही नया है? नहीं, ये अब पुराना हो चुका है. पुराना तो नहीं हुआ, पर ये करंट है. मुझे, I have to, as a teacher, prepare the next generation for the next generation. So these people are leaders in it, but now many people like me have started working in it, and there is some novel thinking here. And what is it? Up till now we have seen that placenta is the villain. We just saw the second wave of trophoblastic invasion failing and this and that, blah, blah. But the novel thinking which is coming up and which is catching our eyes is, it may not be the placenta, but the maternal cardiovascular system which might be at fault. What do I mean by this? I will tell you. Obstetric vasculopathies occur due to problem with mother's cardiovascular system. In an already compromised cardiovascular function, before the pregnancy adds to a heavy load, resulting in a series of adverse manifestations, which you call as vasculopathies. So this is a new thing. So that we are shifting from the placenta to the mother. And what is important for you is that the placenta is not the villain. Actually, the placenta is the victim. Because there is inadequate perfusion in the maternal system, because her mother's cardiovascular system is not able to push in adequate blood, the entire trophoblastic invasion, all this if poor perfusion takes place, what I showed you in the picture, and the reactive oxygen species coming in, and the entire vasospasm and reperfusion damage occurs. So the source is, according to this now new thinking is, or probably tomorrow's thinking is, that it is the maternal cardiovascular system. I still have got 19 minutes and I will finish in time. Now, what is the proof? I am a man of science. I am not a man of religion. Okay, I am a man of science. I'm differentiating spirituality from religion. They are two different things. Spirituality asks for evidence. This also asks for evidence. See now, you will carefully see this. There are shared risk factors for preeclampsia and maternal cardiovascular diseases. Advanced maternal age. They are, in both these occurs. In both obesity, both these occurs. Cardiovascular problems and preeclampsia. Afro-Caribbean, most susceptible. Smoking, sedentary lifestyle, systemic lupus, even metabolic syndrome. Of interest to my dear friend Dr. Manju. These are shared. Renal, chronic kidney disease में दोनों होता है. There are in chronic hypertension दोनों होता है. ये क्यों होता है दोनों? How do you explain? It's because the maternal cardiovascular system is compromised. The another thing, even if the subject's cardiovascular function is not compromised, in conditions like multiple pregnancy, fetal macrosomia, post-date pregnancy, gestational diabetes, and excessive weight gain, there is a common cause. A relative cardiovascular insufficiency is generated because the baby is large or the placenta is closing down in post-date pregnancy, which leads to its effects on placenta, and the entire preeclamptic process comes into play. Now, if you want to implicate the cardiovascular system, we will have to find proof before pregnancy or very early in pregnancy before the changes start. And for that, the coming events must be able to cast their shadows. So let us examine the events before pregnancy very quickly. Maternal ECG studies have shown, good papers, have shown in preeclampsia or demonstrated significant cardiac dysfunction both before and at clinical onset of preeclampsia. My wife, on the first visit of registration, now she finds that her blood pressure may not be 130 or 90, but even if it is touching 120, 130, 128 or so, she sends for a ECG now and a cardiovascular assessment now. These are the subjects which are of this group. This, I don't know how to pronounce his complex name, but this gentleman's group has shown that preeclampsia was also associated with abnormal cardiac geometry and diastolic dysfunction in majority of pregnancy, pre-pregnancy. Before pregnancy, already their geometry was disturbed. Already their function was disturbed. And now she is having preeclampsia and we are trying to cure the preeclampsia. Balances and all, they have shown that cardiac output was significantly lower in early onset preeclampsia compared with late onset preeclampsia. So if the cardiac output was lower, CVS is affected. CVS is affected and they develop preeclampsia. The incidence of hypertension within 10 years of delivery was significantly higher for younger women. Younger women are not supposed to develop hypertension. But see this interesting observation. Incidence of hypertension within 10 years of delivery was significantly higher for young women between 20 to 29 after preeclamptic pregnancy when compared with older women of 40 to 49 with a non-preeclamptic pregnancy. Digest this. I am coming to you within a sip of water. The lady of 40 to 49 had no cardiovascular compromise. The lady of 20 to 29 had a cardiovascular compromise. Therefore, preeclampsia occurred, preeclampsia went away, and the cardiovascular manifestation in the form of hypertension continued or got manifested. Whereas in the other woman who never had this problem, she never had it subsequently, and therefore they are not having preeclampsia. However, people like me, who are also working in immunology, had suggested that in younger women, the first pregnancy, her immunological system is not sensitized as yet. We use, in the book also I have used the vaccine model. The first dose does not generate protection. Subsequent doses does generate excellent protection. And that is what I mean, that in the subsequent pregnancy, immune system is ready and therefore she doesn't develop. Here they have come with a different explanation. I will give you one more interesting proof. Who are these? These are lady athletes. And there is one interesting thing I would like to share. Look at them very carefully. Or Maninder is an athlete, I know. In one study, it was found that an average in a pregnant mother, the left ventricular mass increased by 40% in 9 months. Please take these words very carefully. When this was compared with an increase in the left ventricular mass of athletes, and these were Olympic athletes, including some of them going on to win gold medals, who have been training for years together. In them, over a period of 24 months, only 25% mass increased. They want more mass, but that mass and this our ma has to get that mass even more than that, around 40% within 9 months. And this lady who is going to run or who is going to jump in the Olympics, if in 2 years could generate a 25% increase only. So now you can understand the next step. How robust must be her cardiovascular system so that she is able to bring about this change. And if the cardiovascular system is not robust enough, then she has much lesser time than the athletes. So inherently compromised cardiovascular system, she will not be able to bring about these changes efficiently. And if there is, and as a result of that, poor perfusion and therefore clinical preeclampsia. Very interesting. Once again, back to primary versus immunology, multi. We have observed that in clinical practice, multiparous women develop preeclampsia less readily than primaries. Why? We said this is immunology, because her system is ready and therefore she is not. There is also a cardiovascular explanation, and that I have already told you in detail. We come to another aspect, probably last few proofs. Now, if preeclampsia was being caused or was the effect of pregnancy, then when preeclampsia goes away, when the pregnancy goes away, the effect should also go away. Isn't it? Preeclampsia should disappear by the time the pregnancy is over. You are seeing it. You are seeing it in uterine involution. Blood volume changes. All of these which happen in pregnancy, from 3.5 liters to 5 liters is the blood volume, which comes back to somewhere around 3.5 liters within as soon as the puerperium ends. But does that happen in all subjects of preeclampsia? No, because if preeclampsia was caused by pregnancy only, then the delivery process should reverse like the uterine involution, which is not occurring. So no doubt delivery does tame down the process and fury of preeclampsia, and we have saved millions of lives, we being obstetricians, and by bringing about those deliveries in preeclamptic mothers. But in many cases, this process of hypertension persists. We know, and therefore we are calling them again for follow-up after 1 month, 6 weeks. And what we find, lo and behold, in quite a few of them, the blood pressure is still high. All other changes might have gone. Why is it not going away? Because her cardiovascular system is already affected, and that has got manifestation. The additional load has gone of her pregnancy. Therefore, there is some relief. So our blood pressure will not touch that 180, 120, 170, 110, but will teeter around 130 over 90, 140 over 90. And these are the cases in whom, rather than only giving antihypertensives, these are the cases whom you should send to the cardiologist to get a CVS assessment done or keep them on watch. Now, if you are going to bring in these theories, then you will require new tools for prediction, because their tools of immunology may not be working so well. However, PI and NDI in uterines will still remain because they are showing the manifestation and they are picking it up there. But biochemical markers are picking up the cause, and therefore you are finding an inconsistency in biochemical markers. Even right now, why? Why biochemical markers are an assistant to color Doppler? Because they are picking up immunological changes. So we will require new tools, and I am making you ready for tomorrow. Tomorrow ready is the fancy word in digital world. If primacy of cardiovascular involvement is accepted, then we need tools that identify a compromised cardiovascular function. Those tools that can measure or reduce cardiac output, increased systemic vascular resistance, and cardiac muscular size early in pregnancy will be able to help you to predict preeclampsia very accurately, quite a large number of cases. You see this slide. This also comes from this team, which is working extensively in this. When the cardiac output, when they measured this in early pregnancy, when the cardiac output was low and the systemic vascular resistance was also high, both factors are key, within around 2 weeks they developed preeclampsia. When the cardiac output was normal, systemic vascular resistance was high, they took around 5 weeks to develop preeclampsia. However, if both were normal, more than 10 weeks to develop preeclampsia, or they never developed because by that time she delivered. This will also have its bearing on the drug use in preeclampsia. Right now, we are using drugs following guidelines. The choice of antihypertensive agent varies as per national guidelines. Despite the fact that drugs have vastly different mechanism of action, we are using the same drug for everything. We require different drugs. Labetalol is the first line because it has been given a guideline in UK and many of us are using. But actually, if you see this, if you accept that this also could be the cause in some of our, many of our patients, then beta blockers have a negative inotropic action, it's pumping action, and chronotropic means a rate action. In such a situation, no good cardiologist would usually choose this drug for a patient with low cardiac output and increased vascular resistance, as found in severe preeclampsia. So we'll have to change the drug. So which drug will come in? I am leaving it here. Which component of cardiovascular has been affected? We will have to see this. Force of contraction is affected, and/or rate of heart, and/or abnormal geometry, and/or diastolic dysfunction, and/or primary or secondary vascular dysfunction. Select accordingly. That is where my obstetricians are going to be master managers. They will be genuine professionals in few, maybe 5-10 years to follow, because no two patients might have the same antihypertensive. She might be also having preeclampsia, possibility of preeclampsia, or preeclampsia, and the other also. And according to her system affected, she will be prescribed that drug. We will have to take inputs from our physician friends. So, friend, to sum up, it seems that it is Maninder, only 34 minutes I have taken. For 4-5 minutes I will finish. What I would like to now summarize it. Bhagwan Buddha was, he is accepted one of the avatars of Vishnu, and rightly so. The middle mark, the Madhyam mark. Is it only cardiovascular? Is it only immunological? No. There is a middle path. Both are acting, coming as preeclampsia. The patient's manifestation is same, but the cause is different. Say like edema, headache. My brilliant teacher, physician teacher, used to tell, what are the causes of headache? There are 51 causes of headache. And he would say 1, 2, 3, 4, 51. All coming as headache. So all these causes are coming as preeclampsia. Just as Dr. Manju Khemani is so much interested in endometriosis, now it is believed that endometriosis is a manifestation of many conditions, not only related to the monocytes dysfunction. No, it is much beyond that, all coming as endometriosis. In the same way, these are coming. So it seems that the contention of this thinking is surely we have to accept it in times to come. And I congratulate Jagsonpal for sponsoring such an event, that such new things are also now coming in, where for day-to-day clinical practice it is going to affect. We have to keep a big space for the placental primacy also, because in all, I have already given you enough hints as to why this is not explainable in all. As has been suspected for quite some time now, preeclampsia is the common set of clinical manifestations coming with diverse etiologies. Trying to explain only one etiology and making it universal fit for all is very dangerous. Thus, it seems as of now that there are more than one causes resulting in preeclampsia and allied maternal manifestations. And that is what clinicians have to be prepared for. And that is what this wise man will be telling us. The clinicians should be aware now, right from your first visit, that this could be a cardiovascular problem. We will need tools that identify a compromised cardiovascular function to predict vasculopathies beyond the biochemical markers, maybe in our investigation armamentarium itself. Scientific way to select antihypertensives will come in, rather than it is just universally guidelines based. The guideline will be this. Try to find out which system of hers is affected, and that will be the antihypertensive. Pre-eclamptic mothers who show persistent hypertension after pregnancy is due to a pre-existent, pre-pregnancy, clinically not diagnosed cardiovascular problem. Please send them now. Don't wait for 3 months and 6 months. Send them now. After 6 weeks in the puerperium getting over, or 8 weeks, send them for a cardiovascular help and let them be under that surveillance. So friends, the only thing constant is change, and you have seen it today. In the last 38 minutes, I have taken you through an entire journey of change. And I know some of you must be feeling deluged. Many of you might be feeling unprepared. That was not my aim. My aim is to be honest to the job which has been given to you. Maninder gave me this job. Last week, I was speaking on a totally diverse topic. The topic was the 3 questions. Before that, I was speaking on near miss situations in cesareans. That was the job which I have been given. And I should be able to bring in my experience as a teacher and share with you, so that I may get your blessings and you can use it somewhere. We don't know. There might be around 70 people, 80 people listening to this. And somewhere, someone in Guwahati or in Kodaikanal, he may be listening to this and might get one patient and might treat it properly. These are my name is not going to be immortal. I have no such delusions. When Maninder said that you are looking young, no, I'm not. But that I have no such delusions. But these ideas will remain immortal. Without name, there will be no name. Nobody will know from where these ideas came. I also got it from someone, and it will be going to somewhere, and some student will be working more, will be finding more solutions. People like Ankit Dogra or Deepika might be picking it up and will be telling their companies, their R&D departments to work on it. That yes, this is something coming up, and this is something which can make you mature from a swanky Mercedes car to a private jet. And of course, his bosses will listen to it. But then for this, we require, in modern science, to be a modern manager. Very alert of what is happening, fully in command of what is happening, very well informed. Yes, I still read for not less than 2 hours every day. My research work still continues in spite of busy practice. Right now, today, my patients are being seen by madam downstairs, or if the load is heavy, she might have postponed those appointments. Sir is not there. Possible. possible way. Usually we share patients. There is nothing like a separate type. But then I don't go there because I have to read for 2 hours. In the morning, I get up early, go strike the gym and come and get myself informed for 2 hours every day still. And we have to be well read. Then and then only we will be able to achieve academic excellence. Thank you very much, and God bless you. Thank you so much. Thank you so much.
Thank you, Dr. Pankaj Desai, as usual. It was a mesmerizing presentation, and beyond artistic, the scientific contents have been beyond our expectations even. And you have started a new thought process, a volcano, which even I have been thinking for such a long time, that CVD is an enigma we still don't know. But before I give my comments, I will expect my expert commentators, Dr. Manju Puri and Manju Khemani, to please come in and start discussions, whatever points they feel is important for us to take forward. Because this is a new thought process where we are starting from. We start from reactive oxygen process, then we go, no, it's not the placenta, which we have been thinking of. Before that, we were thinking of something else. Then we come to now, cardiovascular system itself is responsible, where we should be looking into. Because these are the factors which are important for prevention and prediction, which is the one thing required in a country like India, where we cannot take the burden of the diseases, but perhaps prevention can be easily done. To my expert commentators, then I give my comments up.
Thank you very much, Dr. Okay, Manju,
no, please go ahead. Dr. Khemani, please go ahead. Yeah.
We'll have to discuss. Yes.
Okay. So, Dr. Pankaj, that was very informative talk. And I have I've noted few points, right? So, firstly, you're very sharp. You read on my CV that, I'm doing endometriosis, I'm so impressed, that's very sharp on your point. So, no two people are same, You said, it could be cardiovascular this thing of mother, but unfortunately, till now, the cardiologists do not know what to see in echo to predict that, yes, this one will be more likely to have PIH. Neither we, as an obstetrician, when we see an echo report, we know what to pick up. That's one point. My second point is, you said, uterine artery Doppler is much more informative than and cheaper than the biochemical markers, right? But every ultrasonologist is not very good at measuring uterine artery Doppler. Secondly, when you read these reports at 12 weeks and it's written that there's a notch, not many people are measuring, notch depth index, right? It is not very well known, one thing. Plus, we all know that, this notching, if it persists till 20 when you are doing level 2, then it is important. But by that time, we have already missed the boat, because if we have to start the echo sprint, we have to start it at 12 weeks.
Yes.
Right.
Yes.
So still there is a lacuna, and plus, somehow, I feel that, placenta is formed by tracheotoderm. Tracheotoderm is of fetal origin. And in patients, who develop preeclampsia, this tracheotoderm, which is forming trophoblast, it is not invading the mother's maternal vessel. Even in the decidual phase, spiral arteries are dilated, but this trophoblast is not invading it. So I still feel in my heart of heart that primary fault is in this, because the number of villi are also less. In those patients who develop preeclampsia, IUGR, number of villi are also less. Plus, if you see these biochemical markers, which are produced from the placenta, PAP-A, PLGF, they are also produced from the trophoblast. So the total, this thing goes in favor that maybe, you know, we have to work more on the placental side and mother side, maybe, but I think we are far away from there. This is my personal thing. I'll leave it to you, Dr. Manju.
Dr. Pankaj, do you want to respond to this, or maybe we can have a discussion?
I will respond, but words of wisdom were there. What am I going to respond? Not measuring, yes, that's a practical problem, yes. Madam, but people have started measuring. Right up to Malegaon, right up to Durgapur, Asansol, Dibrugarh. I have seen, madam, I travel, and nowadays through the net, of course, people have started measuring. Now is the time, just as they are doing, I don't want to go into much details of this because that is a trivial issue, but people have started. Can we as teachers, means this is what I say, can we sensitize them to, itna karte ho, thoda aur kar dijiye, ye ho sakta hai. Bas, they are just, I'm just making them ready. That's all, I'll finish that. Trophoectoderm, that is more of interest to me. Madam, I have read about trophoectoderm extensively, covered in my book also. Madam, it is very fascinating. That tissue is very fascinating. Why is it that it should invade? Why is it that in some it fails? In which situation it fails? And that primacy of the placenta, it comes in those cases. But there are other cases also where this was not getting explained. The trophoectoderms were efficient enough, were good in mass, the villi were also good in mass, and still why is this manifesting? You know, why are they clinically not disappearing after pregnancy? These are the researches. And what I love in your point is that you are sensitizing it to the basic, that yes, this isko bhi bhulna nahi bhulenge. इसलिए तो मैंने कहा इसको भी, ये तो है, ये तो हमारे पास बरसों से है ये theory, but we will go still further in these new vistas that ये भी है. So even the other cases in the centuries to follow, madam, then we were dying at 42, and now our science is pulling us up to 78 and 80. That science, that advance will come, and pre-eclampsia we may be able to handle it much more efficiently. So yeah, there is no question of trophoectoderm primacy getting lost. No, trophoectoderm is very vital. I have covered it extensively in both my books, and I agree with you. But this is a totally different facet, and it's fascinating me. And I'm sure you are a teacher. Manju ma'am is also a teacher. It will fascinate you also. एक बात, हमारे गुजराती में एक कहावत है मैडम, एक फ्रेज है नरसिंह मेहता का. I will first tell in Gujarati and then I will translate it in English. Mahi padayate mahasukh mane dekhnara daje jone. Those who have fallen inside are enjoying the bliss. Madam, I invite Manju madam and Manju Puri madam to fall within and let us enjoy that bliss. Let others who are standing outside remain hesitant and remain Daje Jone is out of jealousy. Let them remain jealous. This is in a lighter vein, but I have taken every word of yours very seriously. Yes.
So thank you, Dr. Pankaj, for that. And I actually fall short in my words to appreciate your abilities as a teacher, as a researcher, and as an orator. So congratulations and thank you for such a wonderful talk. Now I go to a different angle. So I feel it is inadequate perfusion. We all agree to that. That is the basis. And we are trying to move from a concept of incompetent placentation to incompetent maternal cardiovascular system. So that is what is the change in paradigm shift, which we are trying to understand. Now, I have done a lot of work in folic acid, vitamin B12, and homocysteine. Hyperhomocysteine. Yeah. So could there be a connection, as far as hyperhomocystinemia in Asian population is concerned, vis-a-vis the cardiovascular dynamics and then the placental, perfusion? Could all this be linked? Because, once you give me your thoughts on that, then I'll share my experiences on the studies related to the nutritional status of the women, of our Asian women, and its correlation with the cardiovascular status of the woman, and then of course the placental, placentation per se. So any thoughts on that, sir?
Yes, ma'am.
Actually, I had written the same points: role of nutrition, infection, role of antioxidants, and predictive test. So cost of test, of course, that is another issue. But the main thing, like Dr. Manju Khemani said, that we are not looking into, perhaps we have to develop new norms, because when we don't find the solution in one direction, like Dr. Pankaj Desai said, we should start thinking in other direction also. Might be the cardiovascular system basically is having problems, which is causing this eclampsia problem. Because that is true in many cases where we are seeing in asymptomatic patients, even heart attacks occurring, even in asymptomatic patients. So there are many markers which we are not looking into. Might be heart rate, might be echo problems, might be force of contractions, anything. But we have to start looking into those new directions. Now up to you, Dr. Pankaj.
Some stray thoughts. You are all wise people. What am I going to add to yours? Inadequate perfusion is the basic. That either it is because the mother is not able to provide, or because, as Khemani madam said, the trophoectoderm and the trophoblasts are not able to go through, whatever. Inadequate perfusion, yes, that's a settled issue. But the point is that I do not envisage a shift in paradigm. A little change of words and it makes a lot of difference. I want you to be inclusive. I feel so. I would like to be inclusive in the sense that ये भी है और ये भी है, ये सब pre-eclampsia करता है. ऐसा नहीं है कि ये shift, ये means ये है और यही है, या ये नहीं है, finish, खत्म हो गया. नहीं, ऐसा नहीं है. कोई कभी-कभी ऐसे भी patient आएंगे जिनको, who will be having this problem, this angle of the immunological basis. There will be subjects who will be coming will also be affecting, might be coming through the cardiovascular. We are getting a corroboration from one of the participants who has said that studies have found that endometriosis is associated with angina and such challenges subsequently. Once again, for you, Manju, our hostess, Madam Maninder, to work on this. You have opened up very exciting areas. But I will be taking you all to this. Hyperhomocystinemia. There is an association of hyperhomocystinemia with recurrent pregnancy loss, missed abortions, with, you said, preeclampsia, with myocardial infarctions. Two of my students, I am fine, Helen Hardy, but two of my students have undergone, and my nephew recently have undergone bypass surgeries or an angioplasty, and they have all had hyperhomocystinemia. Whether there is an association with polycystic ovarian disease, because that is a collateral morbidity. Dr. Durusha is working so much on this. Exciting results. Madam, I am taking your suggestion very sincerely, Dr. Manju. Very sincerely. Whether hyperhomocystinemia, I will take some time, might be some 2-3 years to come with the final answer on this, but I will surely come and I will email you as to where. और ये लेक्चर में मिलते रहेंगे, हम छोटी सी ये दुनिया पहचाने रास्ते, कभी तो मिलेंगे तो पूछेंगे हाल. मैं आपसे शेयर करूंगा मैडम कि अभी मैडम इसमें ये नया है और ये मुझे पता चला है. मैं आज से ही इस पे काम पे लग जाऊंगा, because this is something exciting. Yes, you just as that one of the participants has indicated regarding endometriosis and its association. This association is also known. Nutritional status. In general, we know that our nutritional status is compromised. Agreed. In India, majority, vast. But specific components we will have to pick up. Specific components. Just as you obstetricians, I will not say we, you who have created such a miracle, saved millions of women by picking up only iron and folic acid. How much change you have made about by treating anemia, How many lives you have saved? 1947, when we got independent, we were losing 600 mothers per 100,000. Now probably we have gone even less than 100. Absolute numbers, how many you have saved? Individual, this is the individual attack. We will have to pick up and not a general. And because why I'm telling you, in government hospitals, where I'm coming from, you know, nowadays they are distributing kismis and kaju and these things. I don't know how much that helps. It is their business, none of my business. But individual items, and I'm sure this, as Einstein has said, the most complicated solutions lie in very simple explanations. There will be some simple. Also some simple, say like hyperhemocysteinemia requires a folic acid. What does it require? The treatment of hyperhemocysteinemia.
Can I come in?
Yes.
Yeah, Dr. Pankaj, I'd like to share my publications on hyperhomocysteinemia, folic acid, and B12. Interestingly, we've done a study and published in Journal of Perinatology. 107 women of RPL we took, and 343 women who had normal pregnancy outcomes. We did their homocysteine levels, B12 and folic acid. So 98% of RPL were folic acid replete, and 60% were vitamin B12 deficient. And what we concluded was, it was B12 deficiency, which was is more of a problem vis-a-vis what is folic acid. And even we did another study, which is published in the American Journal of Pathology, wherein in the first trimester, on the first registration visit, we again took 100 patients and we did their folic acid, B12 and, homocysteine. And see, every time 60% of the people are B12 deficient and 97 to 98% are folic acid replete. So, and we studied it further. And we found that patients who have high folic acid and low B12 levels have higher levels of homocysteine. They tend to have, somehow interestingly more effect on the homocysteine, and they are more hyperhomocysteinemic. So this imbalance, and imagine we keep giving 5 milligram of folic acid to all our patients in the first trimester. And what is the requirement? It is 400 microgram. We do not have a tablet. So we unnecessarily keep loading our patients with folic acid, which is actually harmful.
Okay.
For new direction.
That is something which
direction
is
we should be giving more.
Okay, I want to add here. There is a point here. Can I intervene?
Yes, please go ahead. Yeah.
Okay. Life Care Center has passed a nice comment that the problem is related to the nutritional. Yes, sir. Yes, sir, or madam, whosoever is watching. Yes, we are concentrating on that, but now we are going specialization in that as well. Not only in general nutrition, this individual targets are now required for replenishment, and Indians have saved millions of mothers by individually targeting iron, individually targeting some of the nutritional components. Madam, coming to folic acid replete, there is one argument contra also. The cases in whom there was neural tube defects. Okay, in them studies have found that they were folic acid replete, and still in them we gave folic acid, and the incidence of neural tube defect fell sharply. So this is where somebody is now just putting it that we can think of the stores of folic acid. That is one. Second, we come to B12. Madam, yes, B12 is coming in a big way. Actually, if you see the photograph which Maninder has put of mine for this flyer, I look very sick. Madam, that was the photograph that I had just come out from Corona. And I know what beating it gives. I am supposed to have a very regular life, a regular gym goer, 6 sessions a week. And I was originally boasting that, oh, I am this, I am that. No, I don't show my biceps to anybody now. I have come back to sight on earth. No, when it strikes, and let us be very humble about it. But then that is where none of my parameters were altered, madam. Oxygenation was also 98 and 99. But B12 deficiency, yes, and yes, Life Care Center, you're right. But B12 vegetarians predominantly, and quite a big, I come from an area which has, say, Gujarat, adjoining parts of Upper Madhya Pradesh, Rajasthan, Madhya Pradesh, Maharashtra, adjoining areas is the largest vegetarian belt in the world. And that is not because of Hinduism, that is because of the spread of Jainism. Whatever be the cause, we are not going into it, but B12 deficiency. Yes, that is where we will require to work very hard on it. And then its association with hyperhemocysteinemia. Thank you very much for sensitizing us to this. And I will surely work on this. And
Dr. Pankaj,
one more point.
One question.
Yeah,
so you are saying that is the largest belt of B12 deficiency, right? So have you found that?
I will not say that. I will not say that. All associations need not be causations.
Okay, so have you found that incidence of PIH, preeclampsia, spontaneous abortion in these belt is much more? No.
So no, you are right. No, but are we really B12 deficient? Are we we are vegetarians. The association has been found between vegetarians and B12. This is statistics. You are a professor, you know this. B12 or B12 vegetarians में ज़्यादा होता है deficient. Agreed. But इन लोगों में था, pregnant mothers में था. ये मैडम, it will be required to be investigated. Brilliant question. Your question, I'm not putting out at a word of a hand. It's a brilliant question. But this is how inquiries take place. These are scientific inquiries, and we three, coming from academics and Maninder being academic minded, we will be very keen to find out answers. We don't have answers at this stage. But no, preeclampsia is not significantly higher. My paper is there. Therefore, I am telling you, it is not significant. But B12 deficiency amongst vegetarian and preeclampsia, is it high? That specifically I will have to find out. I will work on it. I will show you.
Can I add another dimension to this now?
Please.
This is genetics.
Yes.
So I have also worked on MTHFR gene mutation, okay, with vitamin B12 and folic acid, because MTHFR is required for the conversion of homocysteine to methionine. So if MTHFR gene mutation is there, then the enzyme does not work. It gives rise to high levels of homocysteine. Now, in our population, we have done lots of studies. We have done a study on the genetic thrombophilias in more than 680 women with adverse obstetric outcomes, and very interesting findings came up. Our population, both cases and controls, have MTHFR gene mutation. Both have. So that means our population is genetically or ecologically, it is adapted, and we have MTHFR gene mutation. What we saw in our studies was that patients who have MTHFR gene mutation, okay, if they have an imbalance, if they are high folate and less B12, they produce more homocysteine. So basically, what I'm trying to say is it is the genetic makeup of the women, wherein giving excess of folic acid is going to be harmful. And I'm not saying don't give folic acid. I am saying at least give what is recommended. The recommended is 400 microgram. So why are we giving 5 microgram?
Or give B12, Dr. Manju Puri, or give B12 also.
No, we can test
the balance.
No, at least we can. N number of patients have their knuckles hyperpigmented. N number of them. Each one of you will look B12 deficiency. Why can't we look at that? Why can't if we can
and we'll work on it as regards vasculopathies are concerned?
So
yes,
we are doing a lot of work on
we
that.
We are not getting it, and that is what Ankit might give a recommendation to his people, and even Deepika. Maybe we might get a preparation more rational and more scientific for this. Yes, agreed. Abhi nahi mil rahi hai na, madam. 75 milligrams of aspirin. 35 years before I started. Now everybody of you are giving. And when we were giving, I started giving lectures. Madam, वो जो सुड़ी होती है ना, मैडम वो जो नट क्रैकर वो लेके काटता था मैं ओपीडी में बैठ के और देता था और छुपा के टीचर्स को से छुपाता था और देता था मैडम. तो ये इस तरह से that is okay but someone like Ankit Dogra helped me and it started in Baroda and then 50 75 so 150 75 सब जगह मिल रहा.
So I really request them to come with something like 0.5 milligram of folic acid.
They will.
It is desirable. I think that's what is my opinion.
They see the new thought process, the very important point which you have raised now. कि pharma companies should come up with these folic acid, which is
So-
required 500 microgram.
So I think
Thank
these
you.
were the insights which I thought, and I've thoroughly enjoyed the talk by Dr. Pankaj. And let's see if there are any questions in the chat box so that we can take them.
Dr.
Okay.
Manju, you have to add anything?
No,
Dr.
I
Manju,
think-
Khemani? Yeah.
No, I think that's enough.
I reiterate here the point of Dr. Pankaj Desai, which is my favorite quotation also. The only constant thing is change. So we should always be ready for the change.
There is one question which I have got, and that is regarding the use of anti-hypertensive. The question that has been tossed to us is, other than labetalol, nifedipine. Nifedipine is still being advocated with in quite a few recommendations. Nifedipine is the second drug which is alternative. Yes, yes.
So any more questions from anyone?
I'm checking.
Diet
That's
going wrong is the genesis of all the problems. Life care is Dr.
Dr. Sharda Jain.
or
Sharda
Dr.
Jain.
Sharda Jain is no?
Yeah, yeah.
Endometriosis, then this belt is hard working people who do physical work. About your belt,
You have
Dr.
replied, you have replied.
Yes.
One more point which I would like to make, I think we have a good number of obstetricians, that we really need to think of the epigenetics. You know, what substances are we exposing the fetus in the first trimester? So, you know, no unnecessary drug should be given. We should go back to our older times and
Okay,
not.
there is a question, nice one, which has come from Dr. Bhanumati. I think
Bhanumati is from Faridabad.
I know. I think I have met her once. Should we use the conventional folic acid or the new one? I have the courage to tell, please, though extensive discussion took place regarding the deficiency, the genetic deficiency of the converting enzyme. In the large population-based studies, the deficiency was found 1 in 1,000. Please. Your might be a focus case. I will never doubt anybody's data. So old folic acid is still great. You might be giving the new folic acid to 999 patients when only one required it. This is my only comment. I will stop at this.
Dr. Manju, please comment.
I fully agree. I have told that our population is folate replete and the MTHFR gene mutation has got adapted. So it does not, alter the levels of folic acid, but it does have an impact on vitamin B12 levels. So that should be very, very clear that I am not a proponent of any kind of,
Yes, I know. I have seen you for decades now. I know your nature.
I am not a proponent of
you
that.
don't compromise. I have a point that Dr. Bhanumati or anybody, if you have any questions, my website is there, drpankajdesai@gmail.com. You can even email me. I will surely reply, not immediately, might take some time, but I will surely reply. That is my promise. And as a teacher, we must be able to reply. But if we don't know, we will tell we don't know.
Yeah, we'll be sharing these presentations and all other presentations which we are having on the Pearls of Wisdom series, because we are having a series now. So might be 2 Thursdays or one which is feasible for me. At least one will be doing, and those will be shared on the YouTube of the Jagsonpal and on the website of SMLM also. And whenever Dr. Pankaj Desai is there, he has already given you, because he has also lots of material is there. And I must share with you, today I went to the Google search. I wanted to do what was the vasculopathies and whatever is new. And I came out a review article, it appears good. And I was, let me see what is the date. And I saw the author was Dr. Pankaj Desai. So anyway, it's okay. I'll listen to him rather than go through his review article on that. So that is that. I think we have had a wonderful session. Dr. Manju Puri, you agreed to that? And Dr. Manju Khemani also.
Yes, I thoroughly enjoyed and learned so many new things.
Please be there with our future series also, because we'll be just creating these new thought processes. And I must congratulate Dr. Manju Puri, because the point you have highlighted is very, very important, that we are actually not deficient in folic acid, but
We should
perhaps
do
an
it.
imbalance.
Yeah, we should do
Imbalance
a
of
B12 and folic acid level, and then consider our supplementations and not unnecessarily over supplement a patient. That is my message.
That is Manju Puri, what we are doing in all the things. We just start overdoing it. One point comes up and you see, if the progesterone came, I think right, left, like nutritional supplement, we are giving progesterone. And I should not say it, but not only one root of progesterone. It's the 3 roots of progesterone.
हस्बैंड को भी देते हैं मैडम,
Fourth week.
हस्बैंड को भी देते हैं, हस्बैंड को.
That's a good one.
So anyway,
God bless.
yeah, that was a good discussion, Dr. Manju Khemani, from your also, because you started all these discussions, and we have to look forward. We always, we should look backwards for our experiences, for our negative points, where we have to change our direction. But we should not be scared of changing that direction. Because whatever we'll do, we are not, if we falter, we'll come back. But we should start thinking on new direction, like Dr. Manju Puri is doing, Dr. Pankaj Desai is doing, Dr. Khemani is doing. I started thinking, why after HRT, you are having, even in window of opportunity, patients are having heart attacks. So that means somewhere in the indications, we are faltering on that. Let's look into that. Let's be critical of our own selves, our own actions. And even at smaller points, we can make a difference. It's not that we have to be a big researcher to make a difference. Even the small points can be picked up and a difference can be made. And thank you very much to all of you for being here. And we are just in time, 2:28:27, because I never want to cross the timing.
God bless you. God bless
Good night.
you.
Thank you.
Good night.
Thank you very much for being here. I'm really honored.
Thank you.
So we'll just take a few minutes of yours, little
Yes,
2
yes.
minutes more, ma'am.
No
Yes.
problem.
Please go ahead.
Introducing, for the first time in India, micronized dydrogesterone, Divatrone. For a safer and smoother journey to motherhood, Jagsonpal Pharmaceuticals is manufacturing all the active pharmaceutical ingredients and intermediates concerning dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for Divatrone.
Good evening to all the respected doctors. On the behalf of Jagsonpal Pharma sales team, I, Ankit Dogra, from the Medical Services Jagsonpal Pharmaceuticals Limited, thank you all for this opportunity to connect with you all today. We proudly present to you Divatrone, 10 mg tablets of micronized dydrogesterone for luteal phase support in IUI, recurrent pregnancy loss, threatened abortion, and IUGR. The high quality API of Divatrone 10 mg micronized dydrogesterone with all the intermediates is being manufactured by Jagsonpal Pharmaceuticals Limited in our plant. The quality of our brand Divatrone is backed by the bioequivalence study to prove its clinical efficacy and safety. With these clinical advantages, Divatrone offers a safer and smoother journey to the motherhood at a remarkable reduction in the cost to the patient, providing a more economical therapy at just ₹50 per tablet. Divatrone is readily available at all the counters near you to prescribe. Our sales team visiting you is continuously striving to make your bulk purchase experiences effortless and worthwhile. Looking forward to your support to the newest brand in our product portfolio, Divatrone. Do join us tomorrow for yet another academic feast hosted by the Jagsonpal, involving KOLs in the fields of intrauterine insemination and male infertility. Please note down the webinar ID and register now. Thank you.